Okay, good afternoon. My name is Dr. Peter Kranz. I'm at Duke University, and I'm very happy to be here today for the Spinal CSF Leak Foundation's Leak Week, answering some questions. Before we get going, and as the questions come rolling in, just a few introductions. I'm here today with our nurse, Charles, who's really the backbone of our practice and keeps everything working. He's going to be looking at questions as they come in and feeding them to me. Just a couple of ground rules. We'd ask that you keep your questions general. If you have specific questions, or those are going to be best addressed in the context of a one-on-one doctor-patient relationship. But I'm happy to entertain any other questions short of that about spinal CSF leaks, and we're really looking forward to this. I'm hoping that it's going to be a lot of fun. So with that, I just want to begin by acknowledging my friends and colleagues, Dr. Linda Gray and Dr. Tim Amrine, who have been my partners here at Duke in the work that we do. And I got started with this whole condition about 10 years ago now, when Linda Gray, who's, as I said, one of my colleagues here, showed me a couple cases of these patients with these really strange CSF leaks around their spine. And she said, hey, look at these. We're seeing more and more of these cases, and these people have headaches, and we're trying some things to treat them. And that was really the beginning. At that time, we were seeing an occasional person here or there, but since then, things have really ramped up, and we have found more and more of these cases, really changing what we do in terms of diagnosis and treatment. And it's been a real privilege and a pleasure to be involved in the work for almost 10 years now.
All right, Dr. Kranz, you're getting questions coming in fast and furious.
Okay.
And in no particular order, Lucas would like to know, who is the best person at Duke to contact to be seen as a patient?
Okay. So good question. So if you would like to come here to Duke, then you can give our scheduler Horace a call. His telephone number is area code 919-684-7214. He'll have some instructions for you about getting imaging studies and records that you can get in. And then we'll take a look at all those records, see where we need to go from there, and then one of the three of us will give you a call, talk about your symptoms, and talk about what we need to do next.
All right. Emily would like to know, how long after a blood patch does the headache stop?
Great question. So in order to get some perspective on this question, let me talk about headaches that come after something like a lumbar puncture. So the kind of headaches that you get with a CSF leak are very similar to the kind of headaches you get after a procedure like a lumbar puncture. In fact, they're both caused by spinal CSF leaks. And the treatment for spontaneous leaks, that is leaks that start without procedure or a lumbar puncture, have many of the same characteristics. But whereas when you get it from a lumbar puncture, the hole is usually very small, and those headaches respond very quickly to a blood patch. Sometimes within minutes or hours of getting the blood patch, people have their headaches go away. And in contrast, people who have spontaneous CSF leaks, they often take a little bit longer, and it can be complicated by a condition called Rebound intracranial hypertension, where you have some high pressure. And so usually it takes several hours and sometimes even a couple days for us to get a handle on how your symptoms are responding. So I tend to check in with people the day after the blood patch, and then periodically over the next couple days, but it's usually around a week when I try to make a determination, has it really made a big difference or not, because there can be some day-to-day variation.
All right. Another question is regarding imaging. What is the imaging that we use? What kind of imaging do you recommend?
Okay, another great question. So when it comes to intracranial hypotension, which is the condition that's caused by CSF leaks, the first thing that we like to look at is a brain MRI, and specifically a brain MRI where they've given you contrast through an IV. And the reason for that is that many times there'll be characteristic changes on that brain MRI that can very firmly establish the diagnosis. After we look at that brain MRI, there's actually some other bits of information that we'd like to get, and those include the pressure of your spinal fluid and whether or not we can see a leak on your, a leak of spinal fluid from around your spine. And so here at Duke, we find that the best way to accomplish that is to do a test called a myelogram, or a CT myelogram, where we put a small needle into the spinal fluid at the base of your spine. We can measure your pressure, and then do a CT myelogram at the same time, scan you right away afterwards, and then get some immediate pictures of your spine to see if we see any leaks. Now, it's important to understand that as good as those tests are, none of those tests are 100% accurate. So the brain MRI, for example, captures about maybe 75% of people. 75% of people with a CSF leak will have some positive findings on their brain MRI. In terms of having a very low pressure, which we define as a pressure less than 6, and most people are sort of in the 12 to 20 range. But if you have a pressure less than 6, that's only about 30% of people with CSF leaks will be that low. And about 50% of people will have a leak that we can see on their myelogram. So none of those tests individually is perfect. And so we have to rely on a combination of all three of those tests, plus what your symptoms are, in order to make the determination.
Okay. Jade would like to know if you've seen sealed patients have chronic migraines from nerve damage post-leak.
So it is possible to have headaches after a blood patch. The most important thing that we want to rule out in that situation is something called rebound high pressure. And what rebound high pressure is it is an elevation of your spinal fluid pressure that can come about after we seal your leak. So if your pressure is normally sort of right here, when you're leaking it sort of drops down, and then we seal your leak either with a patch or surgery or whatever, and your pressure goes back up but then exceeds your original pressure. And that can produce headaches. And in particular, those headaches are often sort of the opposite of low pressure headaches. Low pressure headaches are often worse when you're standing upright. High pressure headaches are often worse when you're laying down. And in particular, since you lay down a lot at night, you can feel those high pressure headaches during the night or when you wake up in the morning or anytime you're laying flat. And sometimes the headaches will change in location from a low pressure headache. Low pressure headaches can be felt anywhere, but commonly are felt in the back of the head. And sometimes people will, when they transition to high pressure headaches, will notice that change to around their eyes or across their forehead, or various other places. And there are ways of treating high pressure headaches, a variety of medications. One is called Diamox. It's the first medication that we use if we think you're having high pressure headaches. And so to Jade's question about chronic migraines, the first thing is, we'd want to make sure that you weren't having high pressure headaches afterwards.
All right. Michelle would like to know if someone is not truly leaking but is patched, would you expect them to be more likely to get higher pressure than a definitive leaker?
So if you, there are some people who will have a little bounce in their CSF pressure after a patch, even if they're not leaking. Although the people who the people who get the most severe cases of rebound high pressure, in my experience, are people who are leaking. That's probably because over time your body undergoes a number of physiologic changes to try to compensate for that leak. For example, we don't know what all those changes are, but we think that people dilate certain veins around their spine. They may start producing more spinal fluid. And when that gets shut off suddenly with a patch, that pressure may go up faster than your body can sort of wind back those changes. And so it's not a 100% rule, but in general, the worst high pressure is for people who are leaking. But it is possible to have a little bit of high pressure, even if you're not leaking and you have a CSF or a blood patch rather.
How is our practice at Duke different than some of the other practices throughout the country in how we diagnose and treat leaks?
So at Duke, we have developed a couple techniques in terms of doing the spine imaging, the myelogram, that helps us capture some of the faster leaks. And in particular, we have it set up that we can scan that myelogram, those images of your spine, within a minute or two after we put the contrast dye in. And that helps us capture some of the early leaks or some of the transient leaks. We also have a couple of other tests that we do here for patients who we suspect either have very high flow leaks, very fast leaks, or another condition that we have started to recognize really just in the past couple of years called the CSF to venous fistula, where you have your spinal fluid going to into a vein around your spine. That's a very interesting cause of CSF leaks that's been detected really just in the past couple of years that we're learning about. So we have special techniques that we use to bring those out. And then, the way we do our patching is usually targeted at the site of where your leak is. Depending on where that leak is, we'll use your blood to do the blood patch and or sort of a biological glue called fibrin glue and do the patching that way. But in general, I think there are other places that do take care of CSF leaks and have some a little bit of different techniques. But I think the most important thing is just to go someplace where you have an experienced physician who's accustomed to taking care of CSF leaks.
Heidi would like to know, once we receive records, what is the turnaround time on being seen?
That's a good question, and it varies. Sometimes we can turn it around very quickly, and other times we've got a bit of a waiting list, because even though there are some other places around the country, this is not a condition that's treated, in every local hospital. So I think it depends. It depends. We try to see people as quickly as possible, and also sometimes it can take a little while to get the imaging records in, and we need those records to be able to figure out what exactly what exactly we're going to do, which tests you're going to get, and what kind of treatment you're going to get. So the best advice I can give you is just get your records in as early and quickly as possible.
Zandaya would like to know, how common is it to get rebound pressure after a patch, and can it cause Tarlov cysts or spring a new leak?
Great question. So that is an area that is an active research interest, and I think it depends a little bit on what kind of treatment you have in terms of how often people will get rebound high pressure. For example, I would guess that we see rebound high pressure in some form in about 50% of patients who get a blood patch, and it can be more severe, maybe in 10% or 20% of patients who get a blood patch. After surgery, it seems to be a little less common, and we're not sure exactly what those differences are. But on the other hand, people who have these newly recognized sort of leaks, the CSF to venous fistula, anecdotally, those people tend to get really bad high pressure afterwards, and so sometimes we'll even try to treat them prophylactically for high pressure before their surgery. So it varies. It's an area of interest. How do you prevent that rebound high pressure? How often does it happen, and what sort of things predispose you to it? It's an area that we're looking at in terms of research.
All right.
And let me just say, for people who have joined in the middle, my name's Dr Kranz. I'm a physician at Duke University in the Department of Radiology, and we're taking your questions on spinal CSF leaks here today. We've got about 15 more minutes, and the questions are rolling in, so we'll try to get to as many as we can.
Dr. Kranz, just for context, we've had probably 100 questions.
Okay. All right. Charles is trying to pick some of the questions that may mimic some of the ones that we see most commonly in daily practice. So don't be offended if we don't get to your question. There are 2 more sessions this week, tomorrow with Dr. Ian Carroll from Stanford, and Friday with Dr. Sheving from Cedars-Sinai. So definitely come back to the Facebook page for those sessions if you don't get your questions answered.
Another process question, Dr. Kranz. People would like to know, how is the best format to get records to us? If we've joined the digital age, or do they still need to mail in records and images?
Yeah, so I would just talk to our scheduler, Horace, about that. Again, his number is 919-684-7214, and he'll guide you through all that.
Ellie would like to know if you think multiple patches could be a reason for more high pressure after patches.
I think that that with any given patch, you're at risk for high pressure. And if you already have some high pressure and get another patch, it could certainly push your pressure up even higher. I think it's really important before you get another patch, if you have headaches and you get a blood patch and you're having some more headaches afterwards, I think it's important to try to distinguish whether those new headaches are persistent low pressure headaches or some high pressure headaches. And occasionally we have to check the pressure of your spinal fluid again to make sure that that we know where it is. I don't think that, with the third patch you're at a dramatically higher risk of having high pressure compared with the first patch if you're starting from the same pressure. But if your pressure goes up in between, then yeah, it can continue to push you higher.
Laura would like to know, what is the procedure or the protocol for patients who have had patches that have not been successful, particularly with cysts?
So I think everybody's different, and I would hesitate to put one protocol around it. But you talk about cysts, and the cysts are a good question. That's something I get a question about very frequently. So let me just talk about that for a second. So along the nerve roots, as they exit the spine, there are frequently these small diverticulum or outpouchings. Sometimes we call them cysts. Along those nerve roots. Now, people without CSF leaks often have those cysts as well. So, so just because you have those cysts doesn't mean that you have a CSF leak. On the other hand, we know that some of those cysts are predisposed to leaking. So we look very careful at them when we see them. And there are certain configurations and types of those cysts that are a little bit more suspicious than others. So I think we'd have to look at your imaging and take a look at those cysts. There was a time when people would come in and we would patch every single cyst that we could find. And I think we've learned some lessons since then. We're a little bit more selective about where we patch and how we patch. But everybody's different, so we'd have to take a look at your imaging.
All right, Dr. Kranz, a couple questions have come up about types of glue and patching. Can you explain a little bit of the difference between a blood patch and fibrin glue?
Yeah, great question. So fibrin glue is a biological product. It is the purified components of blood that form a clot. And there is a protein called fibrin and an enzyme called thrombin, and you mix the two together like an epoxy, and they become sticky. And fibrin glue is not necessarily better than blood, but they're different. So fibrin glue gets sticky a little bit faster, and it tends to spread less than blood. And there are times when we know where your leak is coming from, and we can get a needle close to it or get our patch close to it. And in those cases, those are cases where I would use fibrin glue, and we often use it in combination with blood. Then again, there are times when we want the blood to spread, either because we don't know where your leak is coming from, or because it's in a place that's further away from the needle or hard to get to, and we want the blood to spread back there. So those are times when I would just use blood alone. And again, I don't think one is necessarily better than the other. They're just different tools that we have available to us.
Kara would like to know that she's had 2 blind patches and wants to know if leaks. I'm sorry that these questions are coming very, very fast. If a leak must be found to diagnose CSF leak, or what is the percentage of success for patching with blind patching?
Yeah, a good question. So first of all, you don't have to actually visualize a leak to be able to diagnose the condition. Like I said at the beginning of the session, just based on other factors too, including your brain MRI and your pressure. And then there are some people who we don't have to see the leak in order to give you the diagnosis. As for outcomes, it's a great question. I could speak anecdotally about what the outcomes are. I would say that depending on the complexity of your leak and how hard it is to get to, on average, it's going to take about 2 or 3 blood patching attempts to get it sealed. Now, some people are very lucky and it's one time and they're done. And other folks, we patch them multiple times and they have a hard time sealing that leak, and some things require surgery. But one project that we're involved in here now at Duke is actually tracking outcomes on people with blood patches. So stay tuned for that. Hopefully within the next 6 months or a year, we'll have some better information about how many blood patches people need and what the outcomes are after blood patching.
What imaging, Ashley would like to know, what imaging should a prospective patient have, and should they consult with a neurologist or go straight to a radiologist?
So one of the interesting things about this disease process is that there are multiple people who take care of it. So you'll notice tomorrow Dr. Carroll from Stanford is an anesthesiologist, and on Friday Dr. Shivink is a neurosurgeon. So I think probably more important than the specialty is having somebody who's familiar with the condition. But a lot of people do come to us after seeing a neurologist, because neurologists are often the first line when people have headaches. And there are a number of neurologists who are very knowledgeable about the condition. In fact, one of the pioneers in this disease is a neurologist named Dr. Mokri, who was at the Mayo Clinic, who's still at the Mayo Clinic. The things that we look for before you come are a brain MRI with contrast, because that gives us a lot of information. The spinal imaging we'll typically get once you get here.
Okay, Dr. Kranz, we have 5 more minutes, so let's see if we can squeeze in a couple more questions here. Okay, give me just a moment. We're at 178 questions.
Okay, so they're coming in pretty fast. So let me, one of the questions I get very frequently is whether or not skull-based CSF leaks or leaks that cause fluid to come out of your nose or from your ears cause intracranial hypotension. And the answer to that is generally not. So sometimes there are a variety of things that can cause you to have fluid coming out of your nose. One of those things is a leak of fluid from the bones at the base of your skull, and that is a CSF leak. But this can be a little confusing because CSF leaks that come from the base of your skull usually have different symptoms than CSF leaks that come from the spine. And if you can picture your spinal fluid in your brain as sort of a water tower, okay, there's a big bulb at the top and a little column down below. And when you're upright, the pressure is greatest at the base of your spine. And so people who have leaks further down in their spine get headaches when they're upright, because that's where the pressure is, and the pressure in your head when you're upright is actually normally negative, and it gets more negative if you're leaking. In contrast to that, people who have skull-based CSF leaks, when they're upright, the pressure in their head is negative, and so that's not usually when they leak spinal fluid. And so their headaches usually don't have a positional component to them. And they complain more of fluid. Most of the time they notice the fluid coming out of their nose or their ears, or they may get recurrent episodes of infection like meningitis. And sometimes people do have headaches, but they tend not to be the positional headaches that people get with spinal CSF leaks. And in fact, people with skull-based CSF leaks often leak worse when they put their head down in between their knees, or put their head down. That's when they notice a gush of fluid coming out. So if you have a spinal CSF leak, it's generally not caused by a leak from your nose or your ears. Okay, I think we've got about 2 minutes left, so I can take one more question, and I'm sorry to everybody who sent in all these great questions. We just haven't had time to get to them all. But Charles, do you have one more question for us?
One last question is regarding opening pressures for myelograms. Is the standard protocol, and why do you do it?
So why do we get an opening pressure with a myelogram? So an opening pressure is the pressure of your spinal fluid when we put a needle in for your myelogram, and it's very easy to measure your pressure at that point. It doesn't really take too much longer. But if you have a very low pressure, it can be diagnostic of a CSF leak. So if your pressure is less than 6, there aren't many things other than a CSF leak that are going to cause your pressure to be that low, at least that we know about. And so if your pressure is very low, it's diagnostic. And then it can also help us establish a baseline for where your pressure is normally. And because there are some people who have spinal CSF leaks when their pressure is in the normal range, or even I've seen a number of patients where their pressure is higher than the normal range and they're still leaking CSF, knowing where that baseline is helps us in the future if we're concerned about rebound high pressure or other things like that. And one thing I want to say too is that, you know, we're talking about these normal values with CSF leaks, and I want to emphasize that these are values that are based on our experience in the past. But the reality is that there were probably a lot of people with headaches who don't currently fall into the diagnostic criteria for CSF leaks, but nevertheless actually do have a CSF leak, and we just haven't figured out where to draw the line around this disease condition. And so I think there are probably a lot of people who have CSF pressure problems, either low pressure or high pressure, causing their headaches, and those things are unrecognized, or we're just on the threshold of being able to recognize them. And again, you know, I think that that's an area of active research that we'd really like to see prioritized in headache care. So we're about out of time. I want to again thank my partners Linda Gray and Tim Amrine for everything that they do. And most importantly, I want to say thanks to all the patients out there who are suffering with CSF leaks. I know it's a very frustrating process. I know that it can be very intimidating to have this condition where not a lot of people know a lot about it. Sometimes you feel helpless or hopeless, but I would encourage you to just stick with it. And for those of you who have a CSF leak that's been cured, you know, reach out to somebody who's just in the early stages of this disease process and let them know that it can get better, things do get better, and we will continue to stick with you and try to push research forward, try to push awareness and education forward for all those people who are out there still suffering. So thanks everybody for logging in. Again, thanks to Connie DeLine and the Spinal CSF Leak Foundation. And if you didn't get your question answered, tune in tomorrow. Dr. Ian Carroll at 2 o'clock Eastern Time, 11 o'clock Pacific Time. And then on Friday, Dr. Shevink from Cedars-Sinai, a real luminary in the field, again at 2 o'clock Eastern Time and 11 o'clock Pacific Time. Thanks, everybody.